They're putting on like a little, they can't be throwing in their poles someday. I don't know what. A microphone to put on her. Apparently it's just going to the live stream, it's not on the other. I understand all the words. It's not hard. I can't sit down. I know. Yeah. I also think post presentation anxiety.
Charge?
Yeah. Oh, we want this girl.
I'm not the judge.
Oh, awesome, thank you so much. We're gonna keep time, right? So what we'll do is, at the 10-minute mark, you can create so that. Oh, no, Dr. Constantine is the one who she can do standard level. Okay, so does the speaker do that?
Yeah.
Do you want to know the science outside? Yeah. So that's amazing. So that's why I was watching it. I know. I remember. Yeah, I remember. She asked me. And then, you don't need the money, do you? No. They'll just flip it on. Okay. So, we have those ones. I don't know. There's one. It's right there.
I can be one.
Dr. Abraham was recruiting one people to come to this room, so.
Everybody flocked in.
Yeah, this was the first room they saw. Do you want me to wait until 11 or?
We can start.
Go ahead. Okay. Well, thank you so much for coming today. And this begins the capstone portion of our day. And so we have students who have been working really hard all semester on their capstone presentations, and they'll be presenting those to you today. In session 1, our first presenter is Elizabeth Sanchez Bautista. She's graduating with a degree in biology with a concentration in medical sciences and a minor in chemistry. She was born in Lima, Peru, but was raised in Lakeland, Florida, and has been at SEU for 4 years. She has served as PHSO president, an ACE tutor, a TA, a side peer manager and mentor, was part of Honors and Alpha Chi, was a chemistry research HIV project leader, studied abroad at Oxford University, this is impressive, and presented her research at the NEST conference at Harvard. Following graduation, she is looking forward to attending USF to obtain her PhD in medical sciences. So we're very proud of Elizabeth. So
hello, my name is Elizabeth Bautista, and this is my capstone title, Very Synthetic Pathways of Efavirenz and its Analogs. So I'll first be going over the background of what efavirenz is, and then I'll be talking about my aims 1 and 2, as well as the data analysis for that, then conclusions, limitations, future studies. So human immunodeficiency virus, or HIV, affected over 1 million people in 2021. And while this virus mainly affects women, it mainly causes men to die. So there are 2 types of HIV, 1 and 2. HIV-1 is spread worldwide, while HIV-2 is mainly found in West Africa. And this is due to the simian immunodeficiency virus, which is found in the monkeys that live over there. HIV-1 also has a higher transmissibility, and this is due to it being able to bind to CD4 receptors at a better rate than HIV-2. HIV-1 also progresses to AIDS, or acquired immunodeficiency virus, at a better rate than HIV-2. So there are 3 types of way for the transmission of HIV, and it can be blood to blood, such as using a used syringe, mother to baby. When the mother is pregnant with the baby, she can actually take medication to prevent it, and then sexually through the bodily fluids. So the structure of HIV is a little complex. However, I will be only mainly focusing on GP41 and GP120, since they're part of the first steps of the pathogenesis. So the pathogenesis of HIV first takes place when attachment to the CD4 receptors of the host cell. And so the host cell will usually be macrophages or T cells. And here you can see GP120 binding to the CD4 receptors. Then there'll be a catalytic shift, and where GP140 will then bind to CCR5 or CXCR4 co-receptors. And lastly, there'll be fusion, in which the viral content will enter inside to the host cell, and then there'll be replication of the virus. And lastly, through the budding, there'll be the release of the virus. So the stages of HIV are acute, chronic, and then AIDS. So the acute stage lasts 2 to 4 weeks after infection, and then we have the chronic stage, which is 4 to 10 years, and then lastly AIDS, which is 10 years after that. And then AIDS, if you don't take medication for the first 3 years you get AIDS, then you will most likely lead to death. So let's talk about treatment accessibility. So while in the world we have over 1.5 million patients acquired were infected with HIV in 2021, mainly in sub-Saharan Africa was the largest rate. And this is due to HIV being the education of HIV, how it spread is not largely known in that region of the world, as well as they're not being able to afford the medication. So the medication of HIV is antiretroviral therapy, or ARTS. And so this is a combination of several types of drugs or inhibitors. I'll be focusing mainly on NNRTIs, which is a non-nucleoside reverse transcriptase inhibitor. So how NNRTIs work is it binds allosterically to the binding pocket of reverse transcriptase and stops the DNA replication. So a type of NNRTI is efavirenz, and it was for HIV-1. And efavirenz cost around $6,000 for 6 months of the medication, which is taken orally. And I'll be focusing on the synthesis of this side chain called cyclopropylacetylene. So how cyclopropylacetylene works is that it binds right here and interacts hydrophobically with tyrosine and tryptophan and causes an 18-degree shift in which it stops the reverse transcriptase from replicating the HIV virus. And here's cyclopropylacetylene. So the original synthesis of cyclopropylacetylene uses butyl lithium, which is flammable when exposed to oxygen, as well as there's only a 50% yield. And so that's why I proposed my aim 1, which is to determine a greener and safer synthesis of cyclopropylacetylene that increases the percent yield with a new base and solvent pair. So my new synthesis would also work with 5-chlor-1-pentyne. Then we would try to figure out what the base and solvent necessary would be used to synthesize cyclopropylacetylene. So potassium terbutoxide and cyclohexane were my first base and solvent pairing. And what we did was we did reflux as well as distillation. So here's an image of our last step, which was simple distillation in the cold room. We were only able to use the cold room for our first synthesis because it then was broken. And then this is the final product of our distillation. And then the second base and solvent pairing was LDA with THF, and we did reflux as well as fractional distillation. And we used a copper column. Since we were not able to use the cold room, we decided to do fractional distillation to get that purity. Here is our final product. Lastly, we did cesium hydroxide with DMF. So we did reflux, and then we didn't do distillation since the boiling point of cesium hydroxide and DMF are a bit, the boiling point of DMF actually is over 150 degrees Celsius, and so we're not able to take it out from our final product. And then here is what we did last, which was just separatory funnel to get our solution, which also had the orange color, therefore we already knew there was impurities present. So for the data analysis of our AIM-1, we do proton NMR, which is nuclear magnetic resonance spectroscopy. And what NMR shows is it shows certain peaks at a certain range, and the protons present at certain carbons are the peaks, and therefore we can read it to get what structure we have. So here is proton NMR of the original cyclopropylacetylene. TMS is the standard that we always use, so it's always going to be at 0. Here we have CH2 present for these two, and then we have CH here for this proton as well as the CH for the acetylene. When we compared the original cyclopropylacetylene to the product obtained with potassium terbutoxide and cyclohexane, we saw that we didn't get the cyclopropylacetylene peaks that we wanted, and so we got turbinol with water. And then for the product of LDA with THF, we also only got diisopropylamine and our solvent. We also had some unknown peaks present. And then lastly, for cesium hydroxide and DMF, the product obtained had only tiny little peaks in which we had to zoom in really big. As you can see here, the TMS peak was really large, and we were not able to determine what it was. So even though my AIM-1 was unsuccessful, I had proposed my AIM-2 before I got those results. And the reason why I proposed AIM-2 is because I wanted to figure out a way, how do I just eliminate the ring strength present? And so my AIM-2 was to synthesize cyclobutylcenylene through the newly found mechanism of AIM-1. And so the replacement of the side chain of the efavirenz has been completed in previous studies before. How it's been shown that the IC90 value was the best with the cyclopropylacetylene side chain at 1.7. Therefore, I propose to do a cyclobutylacetylene efavirenz analog, and the main reason is because there's less ring strain with a 90-degree angle rather than the 60-degree angle. Therefore, in the synthesis of cyclobutylacetylene, there will be less ring opening, which also decreases the percent yield of the product. So we had to see how would cyclobutylacetylene interact in reverse transcriptase. And so in Chimera, I was able to create the structure of the efavirenz analog with the cyclobutylacetylene side chain. And it would also, I hypothesized that it would similarly interact with tyrosine and tryptophan with that hydrophobic interaction, as well as that 80-degree conformational shift inhibiting reverse transcriptase. So cyclobutylacetylene synthesis would be similarly as a cyclopropyl. We would just add that one methyl group and have a 6-chloro-1 pentine structure, and then figure out the base and solvent, which still need to be determined since AIM-1 was unsuccessful, and then do that ring closure to get the cyclobutylacetylene structure. So the expected outcome for my AIM-2 would be that when we synthesize cyclobutylacetylene, there's less ring strain, thus less ring opening, and so potentially a higher percent yield of our product. So in conclusion, our AIM-1 was unsuccessful. However, the effect of substituting propyl rings with other hydrocarbons is still unknown. But chemistry research has taught me in general that even if you don't get the results you want, you still get results that will further eliminate the pathways in which you will potentially in the future get the product that you need. Some limitations of my study were that the NMR power, we use 60 hertz machine rather than a 250 megahertz, which 250 megahertz is a lot more powerful, and you can notice the difference in the NMRs from 250 megahertz, showing the peaks a lot more clearer, and you can read a lot better, as well as scheduling. Being a college student, sometimes my experiment, I wasn't able to schedule it how I would want it in the time frames, and so doing that sometimes could have led me to maybe making errors by exposing it to different temperatures, oxygen, the time precision, and conversion errors. So in the future, I want to rerun our previous studies with the AIM-1 because I think it's always best to just rerun your experiment at least twice to see maybe if you can make any changes to get the product you want, as well as my second proposed synthesis, which uses cyclobutyl methylketone and milder chlorinating reagents, and using that to create the cyclobutylacetylene structure. I would also like to do other very structural analogs like cyclopentyl and cyclohexyl, and lastly do an in vitro study. I'd like to acknowledge God, Dr. Salvatore, my research professor, as well as Dr. Monkaki, Dr. Straw for being advisors, and Dr. Abraham for being our Capstone professor, the whole HIV research team since fall 2021, as well as CNHS for helping me with Chimera. Here are my references, and thank you.
Questions for Elizabeth?
Yes. Why did you choose this topic?
Yes, so I have been working on this research since fall 2021, and so I put a lot of time and effort into it, and so I decided why not choose it for my capstone.
Do you have an idea where the 2-butanol or diisopropylamine are coming from?
Yes, so let me go back to that. Okay, so the diisopropylamine, So the diisopropylamine, since we used LDA, I'm pretty sure it came from that. And then the terbutanol probably came from the potassium terbutoxide.
Other questions? Okay, thank you, Elizabeth. presenter is Michael Seichman, graduating with a degree in biology with a concentration in medical sciences, as well as a minor in chemistry. He is from Niles, Michigan, and has been at SEU for 4 years. He has spent his time at SEU as a TA, a side-year manager and mentor, a pastoral team student leader, discipleship student leader, and he also did chemistry research. Upon graduation, he plans to take a gap year to work as a medical scribe and attend medical school afterward. His goal is to become a pediatrician. So welcome, Michael.
Hello everyone, my name is Michael Siegman and my senior capstone proposal is on a polylactic acid alteration to pterodermis to treat pediatric third-degree burn victims. It's switching up there, but not up here.
I'll secure your license.
Okay, as I was saying, my senior capstone proposal is on a polylactic acid alteration to pterodermis to treat pediatric third-degree burn victims.
There you go.
Yes, so currently pediatric burns are a major cause of morbidity in pediatric populations. And this can be from things like stovetop burns, recreational fires, fireworks, and worst case scenario, in a household fire. And within treating burns, catastrophic fluid loss is the thing that is most detrimental to the patient. And so especially this is important in children because children have approximately 3 times body surface area ratio to body mass. And so, for example, if I were to lose a milliliter of fluids versus a child, it would be much more detrimental to that child losing that milliliter of fluids. And so this is due to the key differences between pediatric and adult skin. And so within pediatric skin, they have a thinner epidermis, a thinner stratum corneum, smaller corneocytes, less keratinization, less moisturizing factors, and then this further leads to a higher rate of water loss. And some current treatments that are available for all burn victims, including pediatric ones, are skin grafts. And one type is an autograft where they take skin from the host and transplant it to a different part of their body. But this becomes an issue because within transplantation from the person's body, they use expanders to expand the child's skin, but due to the child's small size, this can become an issue. Within allografts, this becomes an issue because it uses donor transplanted skin, so someone who's not the person who was burned. And with this, there's a higher risk of rejection and infection. But currently in the scientific community, a well-studied topic is artificial skin substitutes and tissue engineering. And so one specific type of tissue engineering is called the tissue scaffold, and it provides a framework for growth and organization of cells into functional tissues. And some materials that allow for this are collagen, chitosan, hyaluronic acid, or polylactic acid. And they're engineered to mimic a tissue and can even be designed to release various growth factors. So as you can see in these images, they provide a matrix-like substance where the host tissues can integrate into this. And so a specific type of scaffolding is called pterodermis. It's a brand name of a porous scaffold. And it's made from bovine dermal collagen and includes drainage slits to prevent the buildup of blood and lymphatic tissue. And you can see those drainage slits in the SEM located over there. And so currently the issue with this is that it's only available in Japan, Korea, and Taiwan, and it's not currently specialized to treat pediatric patients. It'll work with pediatric patients, but to take into account their different composition of skin, it can be further specialized to treat pediatric patients. And so this leads me to my specific aim 1, which is to create a polymer-based alteration to existing pterodermis to make it more suitable for pediatric patients. Which leads to my hypothesis that if pterodermis is coated with polylactic acid and the vascular endothelial growth factor is covalently immobilized into the scaffold, this will lead to less scarring, more hydration in the wound, and decreased time for full wound healing. So as I previously mentioned about PLA and VEGF, the reason that these were chosen for coating the pterodermis is because PLA aids in tissue hydration. It doesn't elicit an immune response within the body. It doesn't affect the porous scaffold size. It can also encapsulate growth factors to release as the scaffold degrades. And it prevents VEGF from being denatured. In terms of VEGF, which I mentioned, vascular endothelial growth factor, this plays a critical role in angiogenesis, which is the formation of new blood vessels. And it promotes survival of endothelial cells. And so the way that this is going to be done is by first synthesizing the PLA, which can be seen in the image to the left. And then second, the PLA coating, the pterodermis will be dipped into the PLA solution. And then afterwards, covalent immobilization of vascular endothelial growth factor onto the pterodermis' surface. And then this will further be stabilized by using cross-linking using UV. And in order to characterize if this actually worked or not, we'll use SEM to characterize it. And so as you can see on the left-hand side, this is just an original collagen matrix. And on the right side, this has VEGF on it. And so since this hasn't been done before, I mentioned that pterodermis is a collagen substance. So this is collagen without the VEGF, and this is wood. And so as the pterodermis degrades, it will slowly turn to look more like that as the VEGF is released into the host. Which leads me to my specific aim 2, which is to actually test if this pterodermis alteration would work. So the way that I'm going to do this is to design a go-to-again mini-pig model to simulate third-degree burn pediatric wound healing using the altered pterodermis. And so a go-to-again mini-pig is bred specifically for scientific research. They have similar epidermis and dermis to humans, and specifically in pediatric populations. They have a similar distribution of adipose tissue and muscle, and similar metabolic and hormonal profiles with similar rate of healing and burns for pediatric patients. And so shown right here, here's a larger image. We're going to standardize good-again mini-pig age to human age. And so the two specific age brackets that we're going to be focusing on are infant and child, which are at 2 weeks and then again at 6 weeks. And so for the experimental design, the control group is going to consist of traditional pterodermis as well as skin graft. And within each of these, there's going to be 3 infant tested and 3 child tested. And then leading to the experimental group, there's going to be altered pterodermis tested, which is the proposed difference to the pterodermis. There are going to be 6 infant age standardized pigs as well as 6 child age standardized pigs. And in order to inflict these burns on the good-again mini pigs, there will be a controlled burn method that's going to be used. And so the mini pig will be fasted overnight and anesthetized with general anesthesia. Their hair will be clipped, and then a cautery iron will be used to inflict third-degree burns. And so the standard for that is using 75 degrees Celsius and holding it for 20 seconds. And that would then in turn simulate a third-degree burn. And as you can see over there, there is the 7.5 centimeter wound, and then there's the mini pig wound stress. And so the pterodermis is going to be administered, and the way that this works is over here you can see that the pterodermis will be cut into the shape of the actual wound, and then the circumference of the wound and pterodermis will be sutured together. The gauze will be then applied over the pterodermis, and the gauze will be changed daily. For the analysis, we're going to use ELISA test daily in order to test for VEGF, which promotes angiogenesis. And as I previously mentioned, it's already going to be covalently immobilized onto the surface, so we would expect an increase in that. I'm going to test for interleukin 8, which is a pro-inflammatory cytokine, interleukin 10, an anti-inflammatory cytokine, as well as measuring wound diameter daily and measuring this for 4 weeks. And the expected outcomes that we're trying to see is an increase of IL-8 at the beginning of wound healing. And this makes sense because it's a pro-inflammatory cytokine, so you want inflammation at the beginning of wound healing, but decrease in later stages of wound healing. There'll be low levels of IL-10 at the start of wound healing, and then this will increase later in later stages. And there'll be less scarring in comparison to the control. And then in order to analyze the statistical significance of the difference between the control and experimental groups, we'll use ANOVA and analysis of variance in order to do this. And so some future studies include using human trials to lead to FDA approval in the United States, because as previously mentioned, they're only available in a few Asian countries, as well as possibly using silver sulfadiazine as a coating, which is already something that's used to make a more hydrating environment for wound healing, as well as it has antimicrobial properties. In addition, future alterations could be possibly specified in order to treat it more suitably for chemical burns. I'd like to acknowledge God, Southeastern University, Dr. McConkey, my advisor, Dr. Abraham, our capstone professor, as well as my peers through this journey through Southeastern University. These are my references. And then any questions?
When they originally tested this type of grafting, this scaffolding, was it done the same way with these pigs and introducing pain potential of their burn?
Yeah, so the way that I explain the standardized burn method is a method that they use to simulate burns in any type of wound healing simulation.
Any other questions for Michael?
Why did you choose this topic?
I chose this topic just because the tissue engineering field is very interesting, and also being in like organic chemistry research in the past and trying to use organic chemistry to alter the existing treatments for pediatric burn grafts, it just was something that's part of my interest.
Michael, is it typical that that you use such small groups? I noticed your group sizes, your initial group sizes were rather smaller, I think, at 6 pigs. And
yeah.
would that be enough to have any kind of consequential,
Possibly for this study, it would be enough, but in the future, we could look at possibly increasing it based on the results that we get from this. So a higher sample size would definitely lead to more conclusive results in the future.
So for the pterodermis that's being used in the Asian countries, you outlined the problem really well. Is that being used like pretty standardized in the Asian countries?
Yeah, so it's something that's approved in those countries for use, and so for the 3rd-degree burns, they're used in adults mainly, but not currently specialized for treating children.
Do you know if they plan to be introduced to the United States as well for adults?
I don't know. I'm not sure if they're in any FDA approval process or if there's any testing going on right now, so that's something I have to look into.
It was very interesting, thank you.
Yeah, no problem.
Okay, thank you, Michael. Okay, so let's go back. I'm gonna move that down here for a second. Okay, so our next presenter is Alicia Fountain. She is graduating with a degree in biology with a concentration in veterinary medicine. She is from Tucson, Arizona, and has been at SEU for 4 years. She has served as a TA for the Department of Natural Sciences, conducted field study research, served as a side-peer mentor, and the president of the Christian Veterinary Fellowship at SEU. After graduation, she plans to continue working as a veterinary technician to expand her knowledge and experience with exotic and large animals while applying to veterinary school. So welcome, Alicia.
Hi everyone, the title of my research proposal is Evaluating troponin I as a Cardiac Biomarker in Psittaciformes, otherwise known as parrots, in avian veterinary medicine. So to give you an idea of how my presentation is going to go today, I have an outline. We're going to start with some background information, which will lead me into my rationale. We'll go over my specific aim 1 and specific aim 2, followed by my discussion, acknowledgement, and then we'll have time for questions at the end. So we're going to start with background information on parrots, starting with their populations. Parrots are among the order of Psittaciformes, and there are nearly 400 parrots in the world today. They are among the oldest living and most endangered avian species. One of the reasons that they're so endangered is because of their popularity. They're popular for their bright, beautiful colors, their intelligence, and their ability to mimic sounds. Due to this, there has been an increased demand for parrots as pets, but also in zoos and other animal entertainment facilities. This has ultimately led to their overexploitation and declining numbers. According to the International Union for Conservation of Nature criteria, out of the nearly 400 parrot species in the world today, 38% of them are listed as threatened, vulnerable, endangered, or critically endangered. It is estimated that upwards of 20,000 parrots are held in zoos and other animal facilities today. And according to the American Veterinary Medical Association, there are 10.2 million parrots and 4.6 million homes. Looking at these numbers, we can see that it is clear that parrot populations are declining, but their popularity is increasing. This has made it increasingly evident that there is a great need to ensure that these captive parrots have a good state of welfare, but also access to quality veterinary medicine. So because my talk today is about cardiac biomarkers, we're going to go over some background information on heart disease in parrots, specifically parrots that are in captivity. Parrots that live in captivity are mostly caged for their life, and caged birds compared to birds in the wild are more compromised when it comes to heart disease. And that is due to a couple of negative factors that are associated with captivity. These factors include poor diet, restricted exercise, unusual climate conditions, and parrots in particular are more prone to certain cardiovascular diseases such as atherosclerosis, leading them to have an overall elevated risk for heart disease. Common symptoms in birds presenting with heart disease include coughing, lethargy, anorexia, dyspnea, and depression. Current diagnostic tools in veterinary medicine include auscultation, electrocardiography, radiography, and echocardiography. However, despite having these diagnostic tools, diagnosing heart disease in parrots is rare, and that is because these tools are not commonly used in avian medicine. The reason that they're not commonly used has to do with the number of factors that include the anatomical and biochemical differences between avians and mammals like cats and dogs, but the biggest significance is their stress intolerance. Birds in general have a very high stress intolerance compared to other animals you see in the clinic like cats and dogs. In fact, an overall healthy bird, if they're too stressed out, it could cause risk to their health. Therefore, anesthesia is usually recommended in doing some of these diagnostics. However, when you have a bird coming in presenting with these common symptoms, their overall stress intolerance is even more elevated, and anesthesia is way too risky for them. Therefore, oftentimes anesthesia is withheld. These diagnostic tests cannot be done. Heart disease goes undetected, and diagnosis of heart disease in parrots is usually not possible until postmortem. So we're going to jump gears for a little bit and talk about troponin. Biochemical markers are non-invasive diagnostic tools used in human medicine every day, and cardiac troponins are one of those biochemical markers. They are proteins involved in cardiac and skeletal muscle contractile structures. Whenever there is damage done to the heart muscle or skeletal muscle, these proteins are released into the bloodstream and they're able to be detected with certain tests. There are currently three isoforms of cardiac troponin that exist. There's CTNI, which is cardiac troponin I, cardiac troponin T, CTNT, and cardiac troponin C, CTNC. Out of these three isoforms, CTNI is considered the gold standard for non-invasive diagnostic tools for myocardial injury. And the reason why that is preferred over CTNT or CTNC is because those two other isoforms are also excreted into the bloodstream by skeletal muscle, meaning when they're detected in the bloodstream, there could be some question if it came from damage from the heart muscle or skeletal muscle, whereas CTNI is only excreted by myocardial cells, leaving no questions about its origin and making diagnosing heart muscle damage quick and effective. So for that reason, we are going to be focusing on CTNI, troponin I for this study. So due to its success in human medicine, CTNI has been considered a strong cardiac biomarker for avian medicine. The protein has been presented between animals and humans with a 95% amino acid sequence homology between humans, dogs, and cats, and a greater than 70% between humans and chickens. Therefore, human and mammalian CT&I assays may successfully detect CT&I in cardiac injury-prone birds such as parrots. So in order to test for CT&I in the bloodstream, you have to use special assays. CT&I assays are enzyme-linked immunosorbent assays, otherwise known as ELISA assays. There are currently 18 commercial CT&I assays available in human medicine today, many of which have been successful in detecting CT&I in cats and dogs, but there's not a lot of research about its use in avians. However, there was a study conducted in 2017 that used double-crested cormorants, which is a type of bird. They were caught from the wild and topically exposed to oil, and CT&I assays were used to accurately detect CT&I. The assay used was Center Cardiac Troponin I T&I Ultra assay, and this is the first time the CT&I assay has been validated in an avian species. However, the health of the wild double-crested cormorants could not be proven, and differentiation and the damage induced by the oil in this study was not possible. Therefore, further investigation is needed to validate this CT&I assay in other avian species. So this leads me to my rationale. Let's go over everything we just learned. We know that parrot populations are declining, but their overall popularity is increasing. We know that they have an elevated risk for cardiac disease. We know that they have a high stress intolerance, but there's a lack of non-invasive testing. And we know that CT&I is considered the go-to myocardial damage biomarker. Therefore, this leads us to the fact that avian veterinary medicine is of dire need of an easy, accessible, non-invasive cardiac diagnostic tool. It is the utmost importance that veterinarians can offer these parrot patients a great quality of medicine, potentially bettering the life of millions of parrots around the world. So this leads me into my specific aim 1, which is to determine the effectiveness of Center Cardiac Troponin I CT&I Ultra assay at detecting CT&I in parrots. My hypothesis is that this assay will be successful at detecting CT&I in the plasma of parrots presenting with signs of cardiac disease. So my inclusion criteria for this study will be parrots presenting to the clinic with symptoms of cardiac disease and parrots that already have an established doctor-patient relationship with their veterinarians. My experimental group will include at least 80 samples from suspected cardiac disease parrots, and my control group will be 80 samples of healthy parrots. The first thing that we'll need to do is collect the blood. Parrot patients will be restrained briefly without anesthesia, and blood will be collected from a heparinized syringe from the jugular, basilic, or dorsal vein. The assay that we're going to use does require a minimum of 0.1 mLs of plasma, therefore 0.2 mLs of blood will need to be collected. Next, we're going to separate the plasma. The blood will be immediately placed into heparinized tubes, centrifuged at 10 minutes to separate the cells from the plasma. The tube will be tagged, labeled, and stored at 4 degrees Celsius, and then at a negative 80 degrees Celsius within 48 to 72 hours to preserve the plasma for later analysis. Step 3 is to do that analysis. Samples will be analyzed according to the Center Cardiac Troponin I CT&I Ultra assay manufacturer instructions, and samples will be compared to the limit of detection, which is 0.016, and the information will be logged. My expected outcome is that this CT&I assay will accurately detect CT&I in clinically sick parrot patients presenting with cardiac disease symptoms. My specific aim 2 is to improve the cardiac system examination criteria based on the clinical symptoms identified in parrot patients with detected CT&I values. My hypothesis is that this will improve the process of non-invasive avian cardiac assessment based on the data obtained from patients that were involved in this study and had detectable CT&I values. So the methods for specific aim 2 will actually start when the patient comes into the clinic. The veterinarian will do a physical examination that will include auscultation, preorbital skin color, body score condition, abdominal distension, hypothesis levels, and hydration levels, and overall medication. A gross history will also be obtained that will include the patient's age and sex if available, medical history, dietary information, and husbandry information. If it's safe for the patient, cardiac examination will be completed with those diagnostic tools we went over earlier. And a veterinarian will evaluate all this information and compare it to the information to the positive and negative CT&I values that were determined earlier in the study to see if there's any outlying variables present in the clinical assessment of parrots with myocardial injury. My expected outcome is that this will supply clarifying evidence of cardiac disease in parrots to improve non-invasive assessment in hospitals and improve antemortem diagnosis and treatment in parrot patients. So for my discussion, accurately detecting cardiac disease in parrots could prompt faster and easier recognition of disease symptoms. I believe the success of this study could assist in evaluating the severity and prognosis of parrots with heart disease, aiding in the targeted treatment and myocardial injuries and conditions. There are some possible limitations in this study that include inefficient plasma samples, limited volunteer veterinary hospitals, and limited patient numbers. Future studies should focus on further evaluating the central cardiac troponin I, CTNI ultra assay, and other avian species. For my acknowledgements, I'd like to thank God because nothing's possible without His grace. I'd like to thank my family, especially my husband, who's away on military orders right now. Professor Hughes, who's my capstone advisor, and Dr. Abraham, who's our instructor. You guys have given me a lot of grace this semester. And Dr. Nemesian, who's a veterinarian that I work with, who gave me a lot of help and insight on this topic, and my friends and peers.
Yeah, so I have 2 parrots, so I love this topic. But great job. I was just wondering if you think like the stress in an appointment for the parrot, like do you think that would kind of confound, especially it seems like a very sensitive assay for the troponins. And then is this like on the hypothesis that they'll have chronically elevated troponins?
Right, exactly. So troponin, especially CTNI, is one of the proteins that stays elevated for a certain number of hours compared to other cardiac biomarkers. So I do think that this study has to be careful with the overall stress of handling these patients. One of my limitations was the number of patient numbers. I think one of the reasons why birds are not often seen in clinics is because there's just not a lot of clinics that has the skills or equipment to see avian patients. However, if you have a tech or a veterinarian that is familiar with bird anatomy and is used to drawing blood samples can actually be obtained pretty quickly from bird patients without anesthesia. So you just have to make sure you have that person with the right skills to do it. Did that answer your questions? Okay.
That's a question. In your first aim, wasn't it, it was to assess if there had already been injury, correct? In the first aim?
Right, so the first aim.
If the CTI would still do that, and yet, in humans, does the troponin drop off after how long in the human? I believe, I was trying to look it up, I think it's like 2 weeks. So will you necessarily see it if it's?
Right, so another, this kind of goes to the limitation of patient numbers. Another reason why a lot of birds are not brought into the clinics is just because people are really unaware of the symptoms. So sometimes they're brought in too late. So, I'm sorry, remind me of your question again. So
my question is, can you effectively use troponin levels for just the general population? Obviously, if it's someone that you're doing routine checkups on and you know that the bird has symptoms of it.
Right.
But if you're just doing it in general to say troponin is an effective use to see if there's damage, it will only catch the damage initially.
Right, so I'm not sure if I'm quite
It
understanding
won't,
your question.
is your first aim, unless I didn't understand your aim right, that's what I'm trying to figure out. Your first aim was to check to see if troponin levels
would be detected in parrots with symptoms of heart disease, yeah.
So, but if it was a chronic, and that's really the question, chronic versus acute, right?
Right.
If it was a chronic symptom, then you wouldn't necessarily see it anyway.
Right,
So you wouldn't know if they had chronic.
Right, so this definitely is just a step towards trying to better the cardiac assessment for birds. That definitely is a question as far as the chronicness of it, because a lot of birds do have chronic heart problems. So that definitely could be a limiting factor as far as it being chronic and not being able to detect those. So by far, there's definitely more studies that need to be done in this. This is just kind of a stepping stone to go towards that direction.
Thank you.
Any more questions for Alicia? Okay, thank you.
Okay, so our next presenter is Cameron Christie. Cameron is graduating with a degree in biology with a concentration in medical sciences. She is from Lakeland, Florida, and has been at SEU for 3 years. She has served as a side care mentor and has been part of the leadership and cheerleading team at SEU. Upon graduation, she plans to take a gap year to work, or an enhancement year, as Dr. Franklin said, right, to work at Watson Clinic and apply to PA school. So please welcome Cameron.
Before we start, give me a second, it's kind of doing the same thing I did with my group. So can you cancel this slide? Yeah, hold on, it moves here, but not on the image. Can you try this mode? Okay, this mode it works. Let's try it out. See, that's kind of so weird.
But it worked for the last one.
Yeah, I don't know what's going on. Give me just a moment before she starts. Let's try one more thing. Slideshow. Beginning. Can you try now? Okay, it works.
Yeah.
Okay, thanks, Cameron.
Okay, so my name is Cameron Christie, and today I will be talking about the longevity of cytokine expression and mesenchymal stem cell therapy post-moderate ischemic stroke. So today I'll be talking about some background information, which will lead me into my specific aim 1 and 2, along with their expected outcomes and methods, leading into my conclusion, and there will be time for questions at the end. So an ischemic stroke overview. An ischemic stroke occurs when an artery is blocked or narrowed by a blood clot in the brain. A blood clot often forms in arteries due to a buildup of plaques, and as you can see in that image, there is a reduction of blood flow due to the buildup of the plaques from the blood clot. This is the most common type of stroke. 86% of stroke patients are ischemic stroke patients. Nearly 15 million people are affected each year, and 1 in 6 deaths from cardiovascular disease were caused by stroke in 2020. This is a picture of my grandpa. He had an ischemic stroke in 2018 and then another ischemic stroke in 2021. So he led my thinking into this topic about trying to come up with a new treatment that will promote neurological improvement long term. So some common symptoms of ischemic stroke are difficulty or slurred speaking, one-sided weakness or paralysis of the face, arm, or leg, sudden and severe headache, loss of balance or coordination, dizziness, and blurred or double vision. And these are some warning signs to look out for. The acronym FAST, F is for face, A is for arm, S is for speech, and T is for time. So it is critical to seek medical attention once you suffer an ischemic stroke. Once you seek that medical attention, there is an NIHSS score. Most physicians use this to assess the patient's prognosis and the degree of their disability. This is known as the National Institute of Health Stroke Scale. Scores are determined from a sum of 15 evaluated assessments. As you can see here, this is an example of the different categories that they will use to assess this. Scores range from 0 to 42, and in my proposal, I will be focusing on moderate stroke patients with a scoring of 5 to 15. So some current treatment, a common one is tissue plasminogen activator, also known as TPA. This is an intravenous injection that breaks up any blood clots. This is widely used because most patients are likely to recover fully or have less of a disability. However, a limitation to this is it has to be administered 3 to 4 hours after the first onset of symptoms. Another common one is a mechanical thrombectomy. This is an endovascular procedure. A catheter is threaded to the blocked artery in the brain. Some limitations are that it is only successful at 24 hours, and it may only be performed in qualified hospitals with strict screenings. So there are actually only a few hospitals that are able to perform this right now. Another common one is rehabilitation treatment, such as speech, physical, and occupational therapy. Most patients have limited functional improvement, and patients still live with permanent disabilities, so that's why there is a critical need to come up with a new treatment that will provide a functional outcome after an ischemic stroke. In my proposal, I will be focusing on cytokines and mesenchymal stem cells to see if they are used interchangeably or if they are used together. So cytokines, their hallmark feature is to regulate inflammation and immune responses for better health and to prevent diseases. They are potent signaling molecules. They're able to regulate local and systemic inflammation. They are able to proliferate. They also regulate metabolism and tissue repair as well. I'll be focusing on pro-inflammatory and anti-inflammatory cytokines. So pro-inflammatory cytokines, they're secreted when exposed to inflammatory stimuli, and those are some examples in the chart of ones that have been used in previous studies, along with an example of anti-inflammatory cytokines, as these regulate inflammation through inhibition and antagonists as well. So these work to decrease pro-inflammatory cytokines in order to enhance brain repair after an ischemic stroke. Now going on to mesenchymal stem cells. They are able to be derived from bone marrow, adipose, or umbilical cord tissue. They have differentiation factors, paracrine factors, and mitochondrial transfer factors in order to improve the functional outcome. In my proposal, I will be focusing on adipose-derived mesenchymal stem cells, as these have been proven to reduce infarction size, improve neurological outcomes. They also lack human leukocyte antigens, which play a role in the body's immune response to foreign substances, so the body has less of a risk of rejection whenever you are using these. They're also able to be stored, easily expanded, and they're also used more quickly. In previous studies, cell therapy within the subacute stroke period has demonstrated stable clinical and imaging outcomes. The MASTERS trial, for example, they administered stem cells within 24 to 48 hours after an ischemic stroke, and they observed a trend in neurological improvement with early administration of stem cells, which leads me to my overall thinking of if stem cells are administered early on, will there be an improvement of neurological function? So how do those stem cells get to the blood, to the brain? They are able to cross the blood-brain barrier. They have leukocyte-like mechanisms enabling them to interact and migrate across the blood-brain barrier. They're also able to undergo cellular deformability, so they're able to pass through the lungs and migrate to the ischemic region of the brain within 2 hours. Other neurological diseases, such as Alzheimer's and Parkinson's disease, have also observed positive outcomes with an intravenous administration of mesenchymal stem cells as well. So this leads me to my big question of, will early intervention of treatment provide the best neurological outcome, and will combined treatment have an even greater neurological effect? This leads me to my specific aim one of to evaluate the longevity of neurological improvements post-intravenous administration of adipose-derived mesenchymal stem cells at 36 hours after a moderate ischemic stroke. My hypothesis will be that if mesenchymal stem cell therapy is administered at 36 hours after an ischemic stroke as a combined therapy, then there will be a long-term increase in neurological function. So we'll be evaluating patients with an NIHSS score of 5 to 15, indicating a moderate severity of stroke. There will be 3 groups. Group 1 will be patients undergoing current treatment of TPA. Group 2 will be patients undergoing just stem cell therapy. And group 3 will be current treatment and stem cell therapy patients as well. So the patients will be cautioned on all risks and complications. Then they will be administered the stem cells intravenously. Then the dosage will be 1 to 2 times 10 to the 6 kilograms per weight, as this is the recommended dosage for clinical trials. And this will be administered 36 hours from the first onset of ischemic stroke symptoms. There will be different neurological assessments conducted, such as the Barthel Index. This measures performance activities of daily living, and this also aims to establish a degree of independence from any help. Another neurological assessment will be the modified Rankin scale. This evaluates the degree of disability in stroke patients. The scores range from 0 to 6, and 6 being the worst of death. Imaging will also be taking place, such as an MRI, as it is able to detect ischemic stroke within a few hours after the first onset of symptoms. And this is an image of an acute infarction due to an ischemic stroke. This is just an example. And then an example of a normal brain. So we will expect to see imaging of a normal brain after undergoing stem cell therapy. So at baseline, an MRI will be completed. And then at 36 hours after ischemic stroke, they will undergo stem cell therapy. And they'll be medically supervised for 1 week. And at 1 month, 3 months, and 6 months, the neurological assessments will take place along with MRI to compare from baseline to 6 months post ischemic stroke. So the Barthel Index, we will expect to see scores to increase above 85 and gaining independence with minor assistance. Modified rating scale, hopefully scores will decrease 0 to 1, so patients will be able to carry out usual daily activities. And in MRI, we will expect to see a reduction in infarction size, and this will all be compared between each group to see which has the best neurological outcome. So this leads me into my specific aim 2 of how does mesenchymal stem cell therapy influence the production of cytokines. My specific aim 2 will be to identify which inflammatory cytokines are most critical in moderate ischemic stroke patients. So my hypothesis will be that pro-inflammatory cytokine expression will decrease after stem cell therapy and anti-inflammatory cytokine expression will increase in order to reduce infarction and negative neurological outcomes. So this will be in the same groups of patients that are also undergoing stem cell therapy with a moderate severity stroke, as we are comparing this across the board if they have a difference in cytokine expression between each treatment. So I'll be using a quantikine ELISA kit to specifically detect the concentration of cytokines. And anti-cytokine antibodies are absorbed onto plastic microplates, and then a second detection antibody with an enzyme will be added, and this is done using a colorimetric reaction technique. Another method that will be used is a mesoscale discovery. This is a human pro-inflammatory 9-plex ultra-sensitive kit. This has improved sensitivity and dynamic range because it uses an electrochemiluminescent compound to detect these cytokine levels, and it is more specific to see if there is a difference in the 2 methods I will be using and which one is more effective to hopefully promote which neurological outcome is best. So at baseline, patients will give a blood sample, then they will be administered stem cell therapy at 36 hours. And then at 1 month, 3 months, and 6 months, they will also be evaluated with a blood sample. So we'll expect to see the pro-inflammatory levels at baseline to be high as this increases inflammation. And then after stem cell therapy, the levels will be low. And then anti-inflammatory cytokine levels at baseline will be low. And then after therapy, they will hopefully be high. So my overall goal for this is to have a new hope for future therapy and to prove the feasibility and efficacy of mesenchymal stem cell therapy administered on an early intervention, as well as provide long-term improvement of neurological function. Some limitations made to this may be different sources of mesenchymal stem cells, any adverse events that the patients may have, and the age of patients, as well as older patients may take longer to have a neurological improvement. Future studies include targeting cytokine expression in mesenchymal stem cell therapy to control the inflammatory response after an ischemic stroke, and to evaluate the effectiveness of combined treatment, if proven to be effective, in those with an NIHSS score of severe ischemic stroke. I would like to thank God for giving me this opportunity, Dr. Solari for being my Capstone advisor, Dr. Abraham for guiding us through this, and my peers and my family. Thank you.
Can you go back to your ELISA slide? So you're using 2 different methods, correct?
Yes,
To measure cytokines. And what did you say that's going to, how is that going, which one are you going to use? Do you see what I'm saying? So which result are you going to use?
So I'm going to use both of them, and hopefully they'll be able to correlate the study of which ones will be, and if there is a difference in them, then in a further study we can evaluate maybe just either the quantikine ELISA kit or the mesoscale discovery if there is a difference.
Okay. All right, thank you.
What's the difference between an ischemic stroke and a trans-ischemic attack? Are they the same?
I believe, so an ischemic stroke is whenever there is a blood clot in the brain, and a trans-ischemic attack tag, I am not too sure on to give a definite answer, but that's something I would love to look up.
Do you want me to?
Yeah, go ahead.
Yeah, TIA, you can have sometimes just like little clots that can cause that, but it's transient and you still have like that opening up of blood supply and
Okay.
such, but it's just transient.
Oh, okay, thank you.
You don't have those, long lasting. And then I just have a question, so I can go for that. So how did you pick the 36 hours? And are you giving it in the 36-hour window, like time they present to 36?
Yes, ma'am. So
Okay.
I picked the 36 because there has been a neurological trend of like the earlier administration of stem cells. There has been an improvement of neurological function with the earlier administration. So I was looking at how early is too early or is it still too late? So we're just evaluating that way. And that could be another limitation, as like the current treatments, how you have to administer them within 3 to 4 hours after the first onset. That could be another limitation, is if the patient doesn't seek quick enough medical attention, then they may not be able to qualify as well.
Other questions? Okay, thank you.
Thank you, Dr. McConkey, for moderating, and thank you all for being here. This concludes session 1 of our capstone presentations. We are going to meet back in this room at 1 p.m. for session 2. So we look forward to seeing you there. Thank you so much again for being here. Great job, presenters. Yeah.
I was gonna answer, but
Yeah, maybe yes.
you did great. It was awesome. Nice and thorough. It was great. Searching it with our good idea. Much better. I love the thing that was rolled.
Yeah.
They kind of transition from one thing.
I hope you like that, yeah. Thank you. Yeah, yeah, I was thinking,
Great job. Try to do
Are we in a little bit? I'm gonna answer, but I know that she was here now. Yeah, like if you get a chance, I'll be around lunch.
Yeah. Faculty and alumni, we're meeting upstairs. Good job, Anisha. Yeah, would you send the link to your family and to Dr. Moore? Or to your doctor? Okay. Watching? Yeah. Yeah. Did he bust you out? Yeah, okay, I was just making sure because, told me that if they are not very early, like you might want to say that, but it looks like everything was fine, so that's so awesome that they could watch you, not be here and watch you. Great job. Yeah. Ready? Yeah. Is your mom watching?
She is like 6 hours.
6 hours?
Yeah, so
Oh.
she's got 6 hours.
How come?
Well, it's 3 hours from home, but she went to Hawaii, so it's 3 hours.
Oh my.
So, yeah.
So it's good in the afternoon because it's still daytime.
Yeah, but her flight also got delayed, so she didn't even get to Hawaii until like 3 in the morning, so all that time.
Oh my gosh.
Yeah.
But I really tried.
Yeah, but plus the links will be saved, I think, recorded, so you guys can, yeah. We can, and I can send the links out to all faculty to even get to see the other presentations. Yeah, thank you guys, I'm gonna get my stuff and, But y'all are coming back, right?
Yeah.
So, I just want to ask, I don't want to say before you speak, but, I